Thank you. Thank you for the present introduction. Good day, everyone. My name is Tang Yuan from the Cancer Hospital, Chinese Academic of Science and of the Peking Union Medicine College. It's my honor to present 5 years outcomes of the study trial, evaluating short-term radiotherapy plus chemotherapy versus correctional chemoradiotherapy for locally advanced rectal cancer. So let's start by setting the stage of why this trial matters. Study trial conducted from 2015 to 2019 was one of the top 3 phase 3 studies comparing the TNT with the chemoradiotherapy for local advanced rectal cancer. Importantly, our 3 years results were the first to demonstrate the overall survival benefits with TNT group for locally advanced rectal cancer. Now let's walk through the trial design. We randomized the local advanced rectal cancer into the 2 groups. The eligible patients will be randomized to TNT or CRT, followed by total mesorectal excision and adjuvant chemotherapy. The baseline criteria of the 2 groups were well balanced, with about 75.6% presenting high-risk features like T4, N2, mesial function invasion, or extraneural vascular invasion. Moving to the initial results we reported a few years ago, at 3 years, as to the DFS, we can see the TNT groups met the non-inferiority margin with the CRT. And as to the OS, crucially, we thought significant advantage with TNT groups. So these findings really put the TNT on the map of the neoadjuvant treatment. While metastasis-free survival and the local recurrence rates are comparables between the 2 groups. So this presentation reports the updated 5 years follow-up results, including DFS, OS, distant metastasis, local regional recurrence. Also, quality of life and anorectal function were also evaluated. So with a median follow-up of 68.7 months, DFS remained the non-inferior in TNT with the CRT, confirming the durability of the TNT's ability. As to the overall survival, OS continued to favor the TNT group. About absolutely 5 years overall survival benefits of 8.4%. While as to the distance metastasis and the local regional recurrence rates, comparables between the 2 groups, about less than 30% in 5 years disease metastasis rates, about 10% in the 5 years local regional recurrence rate. Now let's explore who benefits most from the TNT. The subgroup analysis revealed important interactions. Importantly, any subgroups like age, ECOG stage, TN stage, MIF, and EMVI. We can say non-subgroups showed significant differences in DFS, OS, or DM, which showed the TNT's broad applications. As to the patients with T4 stage and those with location tumor location more than 5 centimeters to anal region, TNT has the better control abilities than the CRT. So this suggests anatomical factors might influence the treatment selection. Now let's shift in focus to the patient-centered outcomes, quality of life, and anal rectal functions. We can say for the surviving patients in the two groups, we can say the quality of life showed no significant difference. While TNT had slight age in emotion functions, which is a meaningful difference for patients of well-being. As to the anal function, we can say measured by vaccine score, there was no difference could be observed. Let's now discuss the treatment failure and the survival status in more detail. While vital status and the local regional control were largely similar, one key difference is that more TNT patients qualified for watching the weight policy due to higher CR rate, reflecting potential for organ preservation. Regarding the failure patterns, largely similar between the two groups, the TNT group had a few isolated regional lymphatic recurrence, suggesting better control for regional disease maybe. In wrapping up, let's recap the key takeaways from the 5 years data. TNT maintains DFS non-inferiority and provides a sustained overall survival benefit over chemotherapy, solidify its long-term efficacy. And the TNT group showed no trade-off in quality of life and the anal rectal function. And the TNT should be recommended as a neoadjuvant option for local advanced rectal cancer, especially for the patients with high-risk futures. These results align with the global effort qualify for the optimize the neoadjuvant treatment, considering both efficacy and efficiency. That's the end of my presentations. Thank you for your attention.
Thank you. And after Stellar 1, we are welcoming Dr. Jing Jin from Beijing for the Stellar 2 trial.